Welcome back to my channel. If you're new here, my name is Galve and I'm a registered nurse and I do have a degree in medical surgical nursing. I create my nursing educational videos to help nursing students and nursing professionals like you with their studies. If that is something that you are interested in, consider subscribing. If you're already a subscriber though, thank you so much for your love and support. I see you. I upload my nursing educational videos twice a week. Please make sure to subscribe now. You hit that notification bell so that you will be the very first to watch my newest uploads. Also, don't forget to give this video a big thumbs up and share with your friends because that will really help me know that you like to see more contents like this. Without further ado, you guys, let's jump into the video. Hi everybody, how are you guys doing? Another week of upload and discussion ang ali ko sa inyo for today, and we were gonna start this week with this discussion about your central line. Yes, like you are seeing on your screen, this is all about your central line. Anything that you have to do from you need to know from indication, the insertion sites, the risks, the compliance of care, and the types of your central line. All of that is going to be part of our discussion for today. Now, this is my own notes. I made this for myself as my reviewer, and I'm about to share it to you today. And I hope that this one will make it easier for you to understand what is all about your central line. Now, this is another concept that I'm be putting on my ICU playlist. If you haven't watched that playlist, the nursing procedures and skills, I'll be putting the actual playlist link in the description box, or whenever the icon button pops out, click the one out because that's all gonna be there. Now, I would just like to take a moment to thank you for for all of you guys who just watched my most recent uploads. I uploaded a lot of videos, a couple of videos about nursing test banking, and those are the most recent questions that came up from the last board exam, and I can see all of the engagements. You guys are really loving it, and I want to thank you from the bottom of my heart. If you haven't watched it though, I'll be putting the nursing test banking playlist. It's on the top of the playlist because it's my most recent one. Please make sure to check that one out because that's all for you. Now, before I further proceed, I'm gonna give you time to subscribe and hit the notif bell for me. All right, go. Alright everybody, welcome back, and like I said, like I promised, today I'm gonna teach you everything that you have to know, everything that you need to know when it comes to your central line. Yes, this is all about your central line. Now, let me proceed with giving you the overview of what is central line. Now, central venous catheter insertion is a standard and often the necessary procedure for critically ill patients. Various access techniques and devices were developed for many indications, including total parenteral nutrition, administration, dialysis, plasmapheresis, medication administration, and hemodynamic monitoring to facilitate further complex interventions such as transvenous pacemaker placement. Central venous access may be attained by various devices depending on the indication for catheter insertion. Broadly, central venous catheters allow for administration of vasoactive medications and agents known as venous irritants. Some of the medication actually in the ICU and critical care, such as concentrated electrolytes, what else, chemotherapy drugs, inotropes, those are vasoactive medications and normally given through central line. They're very irritant to the venous, that's why we insert and central line to our patients in the ICU. Now, still catheters are used to perform dialysis or plasmapheresis or as a conduit to insert additional devices for more complex procedures. This activity that we're going to have today, we will review your knowledge when it comes to your central line insertion and central line procedure. All right. Now that we have the overview of your central line, I'm going to proceed and go ahead and discuss to you what is central line. Let's answer this question. Okay. So I'll give you 3 definitions of your central line, and I will discuss it to you. So first one, A central line is a catheter that is inserted into a large vein close to the heart. Now, I want you to really pay attention to this key term here. It is a catheter that is being inserted to the vein close to your heart. Oh, sorry. Close to your heart. Now, you might be mistaken this, but there's two large veins in the heart that is normally where the tip of the central line will be terminating, kung saan siya magtatapos. We have here SVC and your IVC. What is your SVC? Superior vena cava, and your inferior vena cava. Bubulol pa ako. Once again, superior vena cava and your inferior vena cava. SVC and IVC. All right. Now, central line is normally single lumen versus multiple lumens. There's some other sorts. There's a lot of types of your central line, which we're going to talk about in a bit. You will see single lumen central line and double up to triple lumen central line, depending on the indication or the reason why we're going to insert central line to the patient. Now, central line serves at different purposes. As I mentioned earlier, some of it we can give it for medication administration, dialysis, dialysis, plasmapheresis, or TPN. But later on, I'm gonna tell you that we don't normally give central line just for the purpose of TPN administration, because we want to make sure that the patient is receiving. We tried all types of all types of management and alternatives for giving feeding to our patient. We can insert NGT, PEG tube, or we can even start with adult puree diet. But the last resort will be TPN, all right? Unless it is the final solution for a patient. Normally, I see patients who are in TPN. Those patients who are critically ill, meaning they are not in their terminal phase of their disease condition. All right. So once again, this is your central line. This is the definition of your central line. Now, let's discuss why are we going to insert central line to our patients. What is the indication of inserting central line? Okay. All right. So we're gonna discuss this one now. Let me just change my pen color here. Okay. I think blue is nice. All right. So indication. I list down several indications here, and I'm going to discuss to you one by one. Now, indication of your central line. First one is ease of access for quick placement. Central line, which we're going to discuss in a bit, there's 3 sites where you can insert central line. And in terms of ease of access and for quick placement, this is definitely one of the things that options that we can give to our patients, especially for difficult cannulation patient. Or kapag sobrang nasa state of shock yung pasyente at hindi mo na maharap, and yung peripheral IV cannula is impossible. So ease of access for quick placement. Next indication is ease of access for blood draws. Of course, if you have central line, it will be, and you're working in a critical area, it's actually very helpful how quickly it is for you to get blood samples and send it to the labs. Although there's actually a high risk for infection. The more you access your central line, the more possibility of introducing an infection to the patient. Why? Because that's actually a portal of entry for bacteria to grow. So later on in the care and maintenance, I'm going to discuss to you how are you going to properly take care of your central line. Next, in terms of medication, we kind of like talk about this earlier, but one of the reasons why we give central line is due to administration of medication. Now, some medications are irritants and vesicants. Infused in small veins is equals to or is equivalent to your issues. What do I mean by this? For example, inotropes. If you're gonna give that peripherally, that will cause problem because it's highly irritant to the veins. So you want to make sure that whenever you start inotropes such as levofed, vasopressin, dopamine, those kind of stuff, you have central line, because or whenever you're giving very high dose of concentrated electrolytes. We normally don't give like 60 mex, or it depends, 80 mex of KCl peripherally. We do need to have a central line because naman KCl is very irritant to the veins. So no, you have to have a central line. Next is I want you to understand that large vein means more dilution, more volume. You can give, especially in an urgent situation or critically ill patients. You normally see them having fluid replacement. They are on fluid replacement therapy, where you kind of like giving, or the doctor is ordering like 200 mLs per hour or 300 mLs per hour to keep that MAP level up, or to hydrate the patient, or sometimes stat dose of 1 liters for 2 hours. A single peripheral cannula can only hold so much, because there's actually a limitation to it. Here's a tip. If you're gonna take a look on the packaging of your peripheral cannula, and it's actually goes the same way with your central line, the packaging of your central line, the CVC, you will see there the amount of volume they can hold and they can give in mLs per hour or mLs per minute. So that's actually a quick tip for you to realize and understand that, let's say the gauge 22, which is color blue, it can only hold for this type of for this amount of volume in an hour. You know what I mean? So a large vein is equals to more dilution. SVC in your IVC, superior vena cava and your inferior vena cava, is definitely the largest vein, one of the largest vein in the heart. And you want to use those veins in delivering high amount of volume or fluids to your patients. Next, certain medications needs central line. What did I tell you about? We talk about your levofed, your inotropes, chemo drugs, some high or concentrated electrolytes. Okay? Vasoactive inotropes, etc. Now, if you one of the indications in relation to your medication is whenever your patient is having multiple infusions in the ICU, in the critical care unit, you will see a lot of times, alam mo yung term natin sa Pilipinas na Christmas tree. Diba? Ang daming nakasukbit, ang daming nakasabit. Meron kang sedation, meron kang inotropes, meron kang ongoing fluid, meron kang electrolyte, may sodium bicarb, may mga electrolytes ka pang nakasabit, may padugo ka pa. If you have like a peripheral line, you will definitely will not be able to accommodate those amounts of fluids and medication that is going to be given to your patient. Multiple infusions, it is really essential to have a central line. Now, peripheral IV is prone of getting bad or infiltrate, and this infiltration can actually lead to extravasation kapag hindi napabayaan, especially if you're giving chemotherapy medications. This is very dangerous to our patient. Now, when you have central line and you're giving all of these vasoactive medications and highly irritant medications to your patient, you are sure that you have a secure access, provided that the central line is patent, not dislodged, not misplaced, and is fully functioning. You know what I mean? So that is all about the indication for your medication. Now let's proceed. Fluids. Now listen up. Large volume of fluid and blood. Definitely when you have a central line, you can administer large volume of fluid and blood. Let's say your patient is going to receive massive blood transfusion, because there's extreme blood loss and you want to replace that blood right away. Having a central line will have you an ease of access of delivering that blood right away. Ease of access. Now, large catheter of central line is equivalent to your high flow. The larger your central line, which we're going to talk about in a bit, because there's actually quite a big difference when it comes to your single lumen central line, double lumen, and triple lumen. I'm going to touch down in a bit when we reach to the types of your central line, but I want you to understand that large catheter is equals to your high flow of fluids and volume of blood. Okay, now we're done with your fluids. How about nutrition? Yes, one of the indication of central line is for enteral feeding, although this is what we try to avoid. TPN is something that we don't want to really give to our patient unless it is the last resort. Because we can actually give TPN via peripheral line IV. I see this in my practice, and it's not really the definite indication that once the patient is on TPN, let's say is on terminal cancer, terminal gastric cancer, you're gonna insert central line just to deliver TPN. No, we can definitely give it PIV, peripheral IV. All right. So here are some of the other indication why are we seeing, or why are we going to administer or give central line or put central line to our patients. Next is hemodialysis. Hemodialysis is a temporary access. Some patients in the critical area, when the doctor orders CRRT or stat dialysis, of course, definitely you have to have HD line, and that is a temporary access. We're not talking about AV fistula. This is different from your AV fistula. We're talking about your central line. Now this is temporary access, which will be removed right after the dialysis session is being completed, or the CRRT is being completed and no longer indicated. Okay. Now, poor vascular access. If your patient have poor vascular access, meaning difficult cannulation, definitely we can request, or we can see that the patient is going to have central line either be PIC, those kind of types of central line. I will discuss it in a bit. Now, if your doctor wants to measure the hemodynamics status of your patient, that's one of the indication. You can see that they can insert CVP, central venous pressure. If they want to get the central venous pressure, central line is definitely indicated. There's other access, for example, TV pacer, inserting a swan, and cardiac devices. Once again, we had just talked about the indication of your central line insertion. Okay, now we're gonna proceed with your insertion sites. Where do you think are you gonna see the central lines placed in the patient's body? There's three major sites primarily three major sites for central line insertions. Now we're gonna discuss them one by one. Okay, let's start with your IJ. IJ stands for internal jugular. This picture right here is an example of your internal jugular line. Now let me give you a brief description. Now this is the common site for insertion. Why? Because of ease of access. It's quick and easy to see. It's easy access. Now this IJ your internal jugular line terminates where? In your SVC, which is what? Your superior vena cava. Okay? Meaning, yung dulo niya ng tip na to, once na na-insert, kailangan nandun siya sa SVC. And this is normally confirmed through X-ray. Okay? Kailangan may X-ray, confirmatory X-ray post-insertion. Alright? Kung nasa SVC ba siya. Next, you have your subclavian, or what we call your SC. Subclavian, SC. Now, this is how, or this is the site for your subclavian. It's under the clavicle. Now, this is more difficult because of its location. As you can see here, there's a lot of landmarks. I typically don't see doctors inserting subclavian because it's kind of like difficult. Your subclavian artery and subclavian vein are really close to each other, and there could be a big probability of arterial cannulation. So that's why most often I see IJ, or internal jugular side. They're using the internal jugular side. Now, it trades off with if the doctor wants, or you decided to use this, you have to trade off with the risk. I mean, good versus bad, because of the arterial cannulation, the probability of dislodgement and rupture. That could be those are one of the disadvantages of this side. Now, where does this terminates, or where does the tip of your when you use this side, where does the tip of your catheter ends? In your SVC, the same as your IJ, or internal jugular. SVC, superior vena cava. Alright, so we're done with your IJ and your SC. We're now going to the last possible site where you can see your central line, femoral site. Okay, this one. Okay, now this is least preferred. Why? Because of its location, and you can see the arteries and vein in this area are pretty much close to each other. There's high risk of arterial cannulation, and because of its location, it's near to the genitourinary tract. There's actually risk for high infection, which we're going to discuss in a bit. But those are the risks that I'm talking about here, trades off with risks. Now, femoral line is also, before I forgot, used during emergency situation. What are those emergency situation? Let's say the doctor wants to do stat dialysis, or stat CRRT, or you want to do massive blood transfusion, and the jugular line, or the internal jugular vein, is inaccessible because the patient probably was involved in an RTA, and there's maxillofacial damage up to the neck. Then that's not possible. So the femoral line is the next solution for this. Now, unlike your subclavian and your internal jugular, your femoral line terminates in your IVC, or your inferior vena cava. All right, your central line should be placed in the veins that carries oxygenated blood towards the heart. Artery carries deoxygenated blood away from the heart. Once again, you guys, these are the insertion sites where you can possibly see your central line, your IJ, your SC, and your femoral site. All right, now, before we discuss the risk and care of your central line, I want to go and discuss to you the types of your central line. Now, I have here the most common types of your central line, and we were going to start with your PIC. Now, if you're asking me how this PIC looks like, this picture will show you how it looks like. Now, PIC stands for peripherally inserted central catheter. Now, this is inserted in your basilic vein and terminates in your SVC, superior vena cava. And now, this is less prone to infection. Why? Because of its location. It's under it is actually located in the inner arm, so it's not so exposed to the bodily fluids in the mouth, in the nose, or bodily fluids that's located or excreted to through your genitourinary. So it's pretty much less prone to infection, less but still prone to infection. Now, I see this based on my experience. Your PIC line is normally indicated for those patients who's gonna be discharged and is going to receive like home care. All right. So PIC line, peripherally inserted central catheter. All right. Are we good with that? Next type of your central line is this one. We called it tunneled. Have you seen this one though? This is how it looks like. Your tunneled is like normally located or inserted through your what's this? SC, subclavian. Now, you will know that this is tunneled and not a PIC because of its location. And it normally have a hub. There's a hub here, and there's two ports, normally blue and red. Now, it is normally inserted through the skin and access vein under skin with a cuff. This is the cuff. All right. Now, this, because of its location, it's also low risk for infection, and patients normally go home with this line, just like your PIC. Now, the next one is your port. Have you seen port, or what we call this in practice, portacat? Portacat catheter. Now, I've seen this one for chemotherapy patient. Now, this is very similar to your tunnel. I want you to understand that portacat is normally like this device alone. This single, not including this one. This is called a jet can, or like a needle that you're gonna insert in the middle of the portacat for you to administer the medication. And once the medication is finished, you're gonna remove this and put dressing on the portacat and leave it as how you initially initially received it. You know what I mean? Now, this access hub under skin and tunneled to the vein. This is normally given to patient, like I said earlier, chemotherapy, long-term chemotherapy patient. You will normally see portacat, and I've actually had experience like inserting portacat insertion. This is a device almost like as big as a 5 piso. Circular, definitely not flat. It's like a convex. You will feel it, and you normally puncture it in the middle where you insert the jet can. All right. Of course, you're gonna follow a septic technique because you don't want the needle to be contaminated before it reach or it penetrates the portacat. Okay. Are we good with your PIC line, tunneled, and portacat? Very good. Next, we're going to proceed with your hemodialysis central line. Now, this is one of the example here. Now, this is, like I said, temporary. Your hemodialysis central line are temporary access, meaning once the dialysis or the CRRT is completed, then you will remove it. All right. If there's no plan or no indication for dialysis and CRRT, your hemodialysis central line will be removed. Okay. Now, large lumen. Why do we use this hemodialysis central line? Because it has large lumens. And that means we have a faster flow rate. Because in dialysis, normally it depends on the order of 50 ml per hour, 60 ml per hour to accommodate the amount of flow rate that is required to that patient. Okay. Now, you will see here that it comes with red port and blue port. This is what you use to identify your access and the return. Okay, so you will definitely check the patency before you start your dialysis in your CRRT. Now, in terms of pigtail, there's actually some hemodialysis line that you will see, like there's like an additional port here for medication insertion, medication administration, or extraction of blood, or giving blood. Yeah, it's actually provided, but for this one I have the classic one, the 2 ports. Okay, so are we good with your hemodialysis? Very good. Before I proceed, I want to give you time to breathe and grab your coffee while doing that. After you do that, come back and hit that subscribe button and notification bell if you haven't already. Go. Welcome back, you guys. Diba? Thank you so much for doing that. I appreciate you, really. Now, central lines. Okay. Remember earlier I talked about single lumen, double lumen, central line. This is what I'm talking about. You can see in this picture, it's a single lumen central line. It's a double lumen central line, triple lumen, and this is multiple lumen central line. All right. Now, single, double, triple lumen are the most typical ones that you will see. I want you to understand that what's with these lumens? The more lumens that you have, the smaller the lumens, or the amount of fluids or volume of, volume you can actually give to your patient. Here's how it works. Let's say I will draw here. Let me change my pen color para makita nyo talaga. Okay. For example, you have here a single lumen, a double lumen, and a triple lumen. For a single lumen catheter, this entire space is going to be available for the fluid and for fluid to go through to the patient. So you will see that there's actually an ample amount of space. But if you're gonna see, or you're gonna give, or if the patient is having double lumen central line, here's how it works. On the bore, or in this in the bore, you can see here that there's like 2 holes. So they will actually not be able to give as much as fluid as the single lumen, because they will have to divide the space for the 2 lumen to accommodate 2 different fluids. You know what I mean? Does that make sense? Now, how about for triple lumen or multiple lumens, lumen central line? For the multiple lumen, you will normally see here 2 small and 1 large. Okay, so if you're gonna think about it, having this knowledge, if you have a multiple lumen, you want to put the highest volume of fluid that you want to give to your patient. Let's say there's an order of 300 ml per hour. You want to put it on the largest lumen and not on the smaller ones. Why? Because you want to make sure that you want to take care of the line, and you don't want to, alam mo yun, hindi siya mabusted or hindi siya masira. So, also, having this knowledge, you will be aware that if you want to extract blood, you definitely want to get it on the larger lumen. And normally, like I said, on the packaging, it will be stated there. And based on the color, in my experience, the brown one is the largest lumen. Okay, so that's why kapag mag-extract ka sa kanya, madali yung pag-extract mo ng blood. Okay? Now, the distal lumen is actually the largest. Okay, one tip. Now, this may be compatible with power injections if you have syringe pump. Your central line, this central lines is very much compatible to it. Now, flow rates may be limited for large volume, and it states, actually, like I said earlier, it states the French size and the max flow on the packaging. Right before you open it, take a look. It's actually stated there. Are we good? We're good. Now, specialty. Okay, I will explain to you this in a bit. Now, specialty types of central lines, we have here your introducer, your sheath, and your MAC. This is an example of your introducer, and this is an example of your sheath. Now, why do we put this type of specialty central lines? Because of the large lumens that they have, and again, they allow faster flow rate, and to allow access for checking of hemodynamic status of your patient. Let's say the doctor wants to insert TV pacer or Swan PA or other heart devices. Once again, these are the types of your central line. Are we good? We're good. Nakakahinga pa ba kayo? Nakakahinga pa. Mag-proceed na tayo. We're gonna discuss the risks. Of course, there's risks of inserting central line. And first to the list is your bleeding. Especially on patients who have coagulation disorders, there's actually definitely a risk for the high risk for bleeding. What are those blood disorders? Thrombocytopenia, low platelet count, patients who are receiving heparin, you know what I mean? So there's risk for bleeding. Now, this is due to punctured vessel. And mind you guys, this is very life-threatening. So you wanna make sure that you run some PTT. You have baseline PTT, INR, coagulation profile first before you check the coagulation profile first before you insert your central line. All right, if it's permitted. Now, other risks include pneumo and hemothorax. All right. Now, you know that this is air or blood in the lungs, or in the patient, you can actually see kapag lumala, hindi maganda yung pagkaka-insert ng central line, combination of pneumo-hemothorax due to central line insertion. Okay? They're both located, the air and the blood located in the pleural space. And this is life-threatening as well. Now, like I told you, in subclavian line, this is if you use the subclavian site, it's actually high risk for pneumo and hemothorax. Alright? So, kapag nangyari yon, ano mangyayari? Mag-i-insert ng ICT drain, chest tube ang pasyente mo. Diba? Naka-ICT therapy ang pasyente mo kasi para ma-resolve yung pneumohemothorax. In my experience, wala pa naman ako nakikita so far. In Jesus' name. Alright. Next is embolism. Thrombus versus air. Now, this is normally air embolism. This is normally, excuse me, this is normally related to removal or accidental pulled out of your central line. Now, this is rare but potentially life-threatening. Okay? So, kapag may accidental removal or na-pull yung central line mo, nako, talaga naman, ingat po tayo sa embolism because that's one of the risks. Are we good? We're good. Other risks include misplacement and malposition. Now, this is related to insertion, during insertion. Like I told you earlier, we talk about this arterial cannulation. Now, this is most common. Yung sinasabi ko sa inyo kanina na about arterial cannulation, yes, this is very much happening during insertion. Now, this is most common in your IJ because nga sa iyong internal jugular, magkadikit masyado yung artery at yung iyong veins. So, may possibility talaga na magkaroon ng arterial cannulation. Ano ibig sabihin nun? Meaning, instead of puncturing the vein to insert the central line, you nag-through and through or na-puncture mo yung iyong artery, which is what we called arterial cannulation. Now, mayroon namang solution, there's solution on how are we gonna prevent misplacement, and this is through insertion through ultrasound guided. This helps prevent for arterial cannulation and making sure that you are puncturing the vein and not the artery. Now, you can also use color aspiration. Normally, ano bang aspiration na makukuha mo kapag very dark red, that's an indication that you are in the vein. But if it's almost like bright red, that is an indication that you are in the artery. Okay, now this is not a confirmatory, you guys, because let's say for example, for severely hypoxic patient, you will not be able to determine if it's an arterial aspirate or venous aspirate. You know what I mean? So the best thing to do pa rin is to do chest x-ray for confirmation. Okay, post insertion of your central line, you will normally see that the patient they're gonna do chest x-ray para ma-confirm. Visualization po tayo ng yung central line. Okay, now other risk factors include retrograde catheter. Now, what do we mean by this? It means catheter that goes in the wrong direction. For example, yung IJ mo napunta towards the head, nasa ulo, imbis na nasa puso, nasa SVC. Yung subclavian mo, napunta saan? Sa IJ. So, tumaas. Napunta sa internal jugular. Dahil nga, sa location niya, difficult yung, difficult yung site niya. Baka naman na hindi napunta. So, yun po yung mapunta yung tip sa tama niyang puntahan. So, that's retrograde catheter. Okay, meaning bumalik o nag-U-turn. Like that. Now, the next risk is, I'm pretty sure you're familiar with this, infection. Now, I'm gonna give you the risk for infection depending on the site. Alright, so sa SC, subclavian mo, this is the least likely to acquire infection. Least likely, but still you can get infection because definitely that's still your central line, a foreign body that you're gonna insert to the patient. Okay, why is it least risk? Because of its location, anatomical location. Yung location ng SC mo, tinan mo, malayo siya sa mouth, malayo siya sa nose, at malayo siya sa genitourinary. Okay, so least likely for infection. Now, in terms, the next one is your IJ. Now, this is high risk. Why is it high risk? Have you seen your IJ? It's close to the mouth and it's close to the nose. Or kung may ear discharges ang pasyente mo, pwede rin yun. So, it's high risk for infection. Ang pinaka-highest risk in terms of the site is your femoral. Bakit nga? O, diba? Obvious naman yun. Sinabi ko na sa inyo kanina because it's located where your feces and your urine can be seen or can be found kasi dito ine-excrete yung urine tsaka feces, right? So, sa genitourinary. So, pwedeng ito ay yung bacteria ay mag-travel o itong hub na to mapunta dito tapos ma-expose sa tae, ma-expose sa ihi. So, ayaw natin nun kasi that's pwede yung magkaroon ng infection yung pasyente. Bloodstream infection. Kaya nilagay siya sa highest risk. Okay? Now, since we're already talking about infection, hindi pwede nating hindi daanan ang CLABSI o yung tinatawag nating central line associated bloodstream infection. To those of you who are catering patient in the hospital, I'm pretty sure that you have like a CLABSI bundle that you normally document and you check every shift. Okay? Now, this is life-threatening, because you're introducing an infection to the patient is having like a bloodstream infection such as your staph, your candida, your C. diff, what else? What are those bacteria? CRE, pseudo in blood, ayaw mo na mga ganon because that will fall under your CLABSI. Now, your CLABSI is normally related to your insertion, sa insertion pa lang, and sa maintenance and care, which we're gonna talk about now. So once again, before we further proceed, this is all about the risks of inserting central line or for central line patients who are having central line. Okay? Now, we're gonna discuss about the care and maintenance of your central line. How are you gonna take care of a patient who's having a central line? First one is you have to check for line and patency. So how are you gonna check for the line and patency, you have to flush and check blood return. Flushing po tayo every we're gonna give like stat medication, or every we will collect blood samples, and you have to check for blood return, meaning once you see like a blood return, that means you're still in, it's not dislodged or something like that. Now, how are you gonna flush it? Using a 10 ml after a blood return. After you check the blood return, of course, you're gonna flush it with 10 ml normal saline. Now, the manner of flushing it is for using the push and pause method, meaning push and pause, push and pause, push and pause. And that way, we are preventing what? Fibrin clot from forming. So, yun po yung rationale kung bakit gumagamit tayo ng push and pause. Next, one way of taking care of your central line is by not using 3 ml syringe. Why? Because you guys, if you're using a 3 ml syringe, remember that it has a higher pressure and you're gonna put your central line into the state of rupture. Pwedeng ma-busted yan or ma-rupture ng iyong central line because you're using like a smaller syringe that has higher pressure. Okay, so instead of using a 3 ml syringe, you have to use 5 ml and 10 ml syringe in giving medications, in flushing, or collecting blood samples to using the central line. Okay, now draw blood cultures from the line. Don't draw blood cultures from the line. Now, unless it is indicated or it is ordered by physician to order any any bacterial growth or line colonization. If the patient is in septicemia or something like that, and we wanna identify where does the infection coming from. So you're gonna do a peripheral stick or line colonization with bacteria. And like I said, if you're suspecting infected line, what you're gonna do is to discontinue that line right away. Okay, if that's the source of a bacterial growth, you want to remove it in the picture. Okay, now in terms of dressing and site dressing, what you're gonna do is you have to keep the area clean, dry, and intact. We normally use like chlorhexidine. What's this? During insertion we use chlorhexidine soap. And we have this Tegaderm that has it looks like this, square type or oval type, that has like a sticky part to it. Now this one has chlorhexidine. You have to stick it on the main on the port, not on the port, but on this. You have to stick it here to serve as added adhesive, okay, and to serve as added protection. Now dressing, if the border is coming up or coming out, you have to change it right away. Now it depends on your SOP, but dressing is normally every 4 days or as needed. Now remember, if you're using gauze, you have to change it every 24 hours because it is prone for bacterial growth, and remove it every 24 hours. Okay, now in terms of insertion and taking access to the line, you have to use sterile gloves and skin prep. You have to use mask, antimicrobial patch, correct size, of course, and impregnated with chlorhexidine. Now, your dressing is very fundamental skill or fundamental nursing responsibility that you have to comply with in preventing CLABSI infection. Okay? Kapag ka nanggigitata na yung dressing, palitan nyo na yan. Okay? Normally, sa SOP namin, nilalagyan pa namin ng tagging, date of change, the type of central line, date of change, due, kung kailan mo siya ipapalitan ulit, tapos date of insertion, something like that. Okay? Now, line care. Now, the next one is line care. Yeah. So, normally we do line care 72 to 96 hours. We have to minimize the access of the central line, or every time that you will access the central line, you have to scrub the hub. For how long? For 3, according sa Lippincott, 5 seconds. Or sa practice namin, 10 seconds. Ano ba yung hub? Ito Itong hub na to. May ilalagay ka dyan na microclave. Normally, yun yung stopper mo, backflow stopper mo to prevent backflow of the blood or backflow. Alright, so we normally use Curious cups or to maintain the sterility. We normally put sterile gloves, steel scrub for access, pressure caps to prevent blood backflow, and if it's not in use, please make sure to clamp it. Okay, you don't want any air embolism or because you don't want air embolism to your patient. Okay, so you want to make sure that you are clamping it if it's not in use. Now, the last nursing responsibility is to monitor for signs of infection such as redness, swell, and pus discharges. If you see these 3, you have to notify your provider in order for you to do quick actions such as removing it or running, especially kapag may pus, removing it and then running blood cultures to rule out any colonization of the central line. Malinaw ba tayo dito sa ating discussion? Ako, napakahaba nga po, but this is very detailed and I hope that you really enjoy this type of discussion. Once again, this is all about your central line, and let me know if you guys want to have a copy of this lecture because I'm planning to actually provide this lecture for free to all of my Patreons. Saya, diba? So I can just erase this and I can give it to you, the lecture, whenever you are. I actually don't know how to set up a Patreon, but I would love to. Pag-aaralan ko, tapos babalik ako sa inyo, okay? Now, yun lang po. Maraming salamat and I hope you enjoy and learn something for today. Tulungan nyo na nga ako, ipamalitan nyo na sa radyo sila ang pinakabago, pinaka-fresh at pinakalibreng nursing review center sa balatang YouTube. Don't forget to follow me. Check my other social media accounts. Everything is at Neil Galve. Support me as well, except for my TikTok account, which is Neil Galve Official. I will see you again this week for another upload. I'm gonna think kung ano pang i-upload ko, pero definitely I want you to watch out for that because it's gonna be fun. I-click mo na yung notif bell para hindi mo yun ma-miss. Magkita tayo ulit and you have a good day. Goodbye!